the ovoid as opposed to circumferential orifice that are very common in bicuspid disease, the calcium burden, all make the risks to this patient, the longitudinal risks, of concern for a early failure of the device or need for explantation. So we can address that in more detail should you wish. From a surgical perspective, there are really two options. One is a traditional aortic valve replacement, which involves resecting the aortic valve leaflets and replacing it with a biologic or mechanical prosthesis, which we'll get into in a moment, or a Ross operation. And a Ross operation involves taking the pulmonic valve in a supported manner and replacing the native aortic valve using the pulmonic valve, and then replacing the pulmonic valve with a human cadaveric or homograft. The results of the Ross operation in young patients are excellent, inexperienced centers, and that is an option that your patient should at least consider should you have access to that. From a valve replacement perspective, which would be the broadest category, there is standard surgical aortic valve replacement through a sternotomy, through a mini sternotomy, or other minimally invasive manners, including now robotic aortic valve replacement. Your viewers can look into that. I'm sure you'll be able to provide some information online from YouTube or any of the other resources available. The most important thing is to relieve the aortic stenosis and replace that with a functioning valve that would last the longest for this patient. I get this question a lot.